Perfect, then let's get started. Thank you very much for the invitation. I truly love speaking about my passions that I hold close to my heart. And this talk, I think, combines all of them. So let's get started. It's Friday morning. We all want to get to the weekend. So patient blood management, why the big fuss? Why is everybody talking about this? Is it really this important? Is it really such a big deal? So everything we do is centered around patient outcomes. And I don't think anybody on this call this morning would be in the profession they are if they were not focused on patient outcomes. And for me, there's a couple of things that is going to contribute from where I'm sitting in a blood service to patient outcomes. And that is a couple of ethical issues, health equity issues, and patient blood management. But there is also something else in the background that we as doctors tend to forget about, and that is the law. So let's get started. So the aim of this lecture is very simple this morning. I want to leave you with more questions in your mind than when you woke up this morning. So this lecture is not to give you answers. This lecture is to leave you with questions. Let's start talking about global health a little bit. There's a lot of definitions of global health. Personally, I like the one of Copland. It says it's an area for study, research, and practice that places a priority on improving health and achieving health equity for all people worldwide. And when I read this, I immediately started wondering, okay, so what would we say is health equity? And also, again, a lot of definitions, but this one by far my favorite. Health equity is achieved when every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Now we're going to make a quick, slight direction change, and I want to remind you about the Sustainable Development Goals. Now, as you know, the United Nations in 2015 adopted 17 SDGs, and they say this was aimed to end poverty, protect the planet, and ensure all people enjoy peace and prosperity by 2030. And this was a lofty goal, and many of us snickered when we saw this goal, but after we snickered, did we stop and think how we can contribute to these goals? So the SDGs are integrated. Action in one area will definitely affect outcomes in other areas. And we know that development must balance social, economic, and environmental sustainability. So those of you who might have forgotten the 17 SDGs, because I know we don't really think about this very often, these are the 17 SDGs, but the ones that links to this morning's talk is no poverty, zero hunger, good health and well-being, quality education, gender equality, decent work and economic growth, and reduced inequalities. And now many of you are going to wonder, good heavens, this woman, she's here for a patient blood management talk, and she's talking about these SDGs. And I hope by the end of the talk, you will see how this all links together. Quick direction change. I want to talk about iron deficiency. We all know this. Iron deficiency, fatigue, weakness, chest pain, palpitation, shortness of breath, headache, dizziness, tongue soreness, nails, skin changes, cold feet and hand, and you crave unusual food substances. That is what we kind of know. We never forget those. But do we often enough stop to remind ourselves of the negative impacts of iron deficiency in pregnancy and the perinatal period? In pregnancy, we know breathing difficulties, fainting, tiredness, palpitation, sleep difficulties. It just makes the pregnancy so much more difficult for the women. And it just makes them so much more incapable of meeting the demands, maybe at their work, maybe the household that they're looking after, and it really places a burden on them. but it unfortunately also increases the risk of perinatal infection, preeclampsia, bleeding, postpartum cognitive impairment, and behavioral difficulties. And if you think about those SDGs that I highlighted, it will impact on several of them. But we know that the adverse perinatal outcome that is connected to iron deficiency is intrauterine growth retardation, prematurity, and low birth weight. And many of them come with a significant mortality risk. So thinking of iron deficiency anemia and child development, we know that pregnancy places a bigger demand for iron on the mother, and she must either consume more or supplement. And that old Popeye cartoon, when he ate a can of spinach, I think Vernon Lowe always say you have to eat something like 13 kgs of spinach a day to get enough iron in. So obviously that is not the answer. Interesting studying by Lossoff, they found that anemic mothers have a risk of iron deficiency anemia in the fetus, and these babies are born with lower mean ferritin levels. But we also must never forget that the fetal brain rely on iron for optimal development. So the Lossoff group enrolled infants into an iron deficiency study, and then they followed them up for more than 10 years. So what they found is that 20 to 25% of infants suffer from iron deficiency anemia. But here's the scary thing, even more presented with iron deficiency with a normal HB. It's a hidden iron deficiency. So given that the study was to follow them up for more than 10 years, at the ages of 11 to 13, what they found in these children is that they were repeating grades, they had reading and speech problems, they had attention problems, behavioral problems, anxiety, depression, aggression. And now we immediately jump our thoughts to what's happening in our schools recently, what's happening with teenage depression and teenage suicide. And we want to blame it on many factors, but are we not forgetting about one of potentially biggest contributing factors? Do we know what iron deficiency in our teenage population in South Africa looks like? And these children need to be referred to special services and tutoring. And we know that this is severely lacking in South Africa. So these poor kids are set up for failure from infancy. They even went further and they looked at their outcomes at 25 years of age. So they followed this group up to young adulthood. And these children were still the ones that was enrolled between the ages of 1 to 2 years presenting with iron deficiency anemia. And what they find in these young adults that was originally enrolled is that chronic iron deficiency caused 58% of them not to complete secondary school. 76% of those who did complete secondary school did not pursue further studies. 83% were single. They reported poorer emotional health. And at the age of 25, they have never caught up to their non-IDA peers. They struggle to hold a job. So it shows you that chronic iron deficiency have a cascade of adverse outcomes. And now if you think back to the SDGs I highlighted, I think you can now see how we should be asking the right questions in the South African setting. So iron deficiency is bad. It's bad for the pregnant mother. It is bad for the baby that's born iron deficient. It's bad for the teenager. It's bad for the young adult. It's bad for the economy. It's bad for South Africa. It's bad for the world. But what's even worse, if you think that these young adults at around 25 years of age, many of them are females, and many of them fall pregnant, or many of them are victims of violence. And now the slightest bit of blood loss causes them to decompensate. And what we're actually doing is we are treating iron deficiency with a red cell transfusion. And you will see why I'm saying this when I show you a bit of South African data later on. We are now going to talk about what many people consider to be my day job without realizing that everything in this talk is actually my day job, and that is patient blood management. So in May 2010, the 63rd World Health Assembly declared that patient blood management is a basic standard of care, and everybody should be pursuing the applications of these principles. So what is patient blood management? The American Association of Blood Banks says it's an evidence-based, multidisciplinary approach to optimizing the care of patients who may need transfusions. Not the patient who is being transfused, not the patient for whom I'm completing the blood request form, the patient who may need a transfusion down the line. It covers all aspects of patient evaluation and clinical management surrounding the transfusion decision-making process. And again, that decision-making process doesn't start when I fill in the request form. That decision-making process starts when I see my patient in orthopedic OPD and I know I'm going to book them for a hip or a knee replacement. When I see my mummy in the antenatal clinic and I know she is going to have a certain amount of blood loss, even with a normal vaginal delivery. That is when the transfusion decision-making process starts. So this includes application of appropriate indications, minimizing blood loss, and optimizing the patient's red blood cell mass. Another definition is for the SABM, and I like this because they remind us just what I said about the previous slide. It's the timely application of evidence-based medical and surgical concepts to maintain HB, optimize hemostasis, minimize blood loss in an effort to improve patient outcomes. So what is patient blood management? Patient blood management does not say that all transfusions are bad and should not be considered. It remains a life-saving intervention in the right setting for the right patient. Patient blood management requires that all transfusion decision-making processes should show cognizance of patient blood management principles. PBM principles should be applied in all phases of a patient's treatment program, pre-operative, intraoperative, and post-operative when you're going to discharge that patient. If there's an anemia present, the reason for the anemia doesn't disappear when she delivers her baby. You must make sure that you have a post-operative or a post-discharge plan for this patient as well. The focus points of PBM is to timely optimize the patient's own red cells, diagnose and treat anemia, control and minimize blood loss and bleeding, optimize and harness the patient's physiological reserves or tolerance to anemia, to empower your patient with knowledge, and to allow your patient to participate in the decision-making process. And it is a multidisciplinary approach. Patient blood management is teamwork. Several disciplines within your setting, if you take Charlotte Makeke Hospital, but also the hospitals that refer to you and to which you are going to down refer the patient to again. So why should we do PBM? I think the biggest reason for me is because of anemia. The Global Burden of Disease study has in 2015 already estimated that almost 2.4 billion people was affected by anemia. Many of them were in sub-Saharan Africa, as you can think. And almost 1.5 billion suffered from iron deficiency anemia. And I've already highlighted the negative impact of iron deficiency. In South Africa, Prof. Moodley and a colleague did a very interesting study at a regional health facility in KZN. And they found that females presenting at a regional health level, meaning that they have already probably been seen by primary health care or district health care, but by the time they report to a regional health facility, almost 43% of them were still anemic. Now, if you go into a normal delivery anemic, that slightest blood loss is going to cause you to decompensate, and you're probably going to need a transfusion. And that transfusion could have been prevented. There's a multitude of studies that were published to highlight the negative effect of preoperative anemia on patient outcomes. And they have described in all of these studies that pre-op anemia increased morbidity, increased mortality, and increased the need for red cell transfusions. Irrespective of which one you read, there's a key message, and that is that the anemia must be diagnosed and corrected before surgery. Apologies. In South Africa, many of you will know the SASL study, and they looked at 50 hospitals, at elective surgery patients, only elective. And we all know how long it takes from the time that I see a patient in outpatients until I actually get that patient on a theatre list for a knee replacement, a hip replacement, or even an elective hysterectomy. What they found is in South Africa, when these patients were admitted for the surgery, almost 49% of them were anemic. And that is despite the fact that we had ample time to address this anemia. They also found that the preoperative anemia was independently associated with in-hospital mortality and admission to critical care. We all know that transfusions are linked to risk. The best summary I can give you is from this consensus conference, where they looked at almost 35,000 papers, and they searched specifically for transfusion outcomes after allogeneic transfusions. To summarize their findings, they found a dose-dependent negative outcome to transfusions. In other words, the more you give, you should be prepared for more negative outcomes. And those negative outcomes was mortality, serious infectious, thrombosis, ICU admissions, length of stay, and obviously if I transfuse more, your chances of suffering a transfusion adverse event becomes more. Interesting study that was done over 6 years in Western Australia, only adult patients, elective and emergency. They looked at over 600,000 patients. The second author of this paper, Prof. Axel Hoffman, is a health economist, not a medical person. And he also started working with SANBS in 2017 so that we can start driving patient blood management in South Africa. So after 6 years of implementing PBM in Western Australia, what did they find? Their in-hospital mortality showed a reduction, their length of stay reduced, infection reduced, and we all know what the impact of a hospital infection is. Those things are resistant to almost all the drugs. Those poor patients often end up in ICU, and they suffer all kinds of other side effects as well. Their acute myocardial infarcts and strokes went down with 31%. And yes, their readmissions increased because less people initially died in hospital, so they were still alive to be readmitted. I think that makes sense. They also managed to reduce their transfusion threshold safely. Their single unit transfusion rate went up to 64%. Remember the dose-dependent negative outcome. So it's important if your single unit transfusion rate can go up. And their proportion of patients admitted anemic went down quite dramatically. Another systematic review looked at 235,000 odd patients, all surgical, 100,000 pre-PBM, 134,000 the PBM group. And they found that with the implementation of PBM, the transfusion rates went down, the red blood cell units per patient went down with almost half a unit per patient on average. The length of stay went down, the total number of complications went down, and the mortality rate reduced. But we are all working in a profession where there's never enough money to do for our patients what we want to do for them. And therefore, we need to be mindful of cost-effective healthcare delivery. And when I walked into, way back when I started with SANBS and I started attending hospital meetings, the first question I was asked when I walked in was, how much do we owe you? Everybody was so worried about the blood bill. But people tend to forget that the blood bill is the tip of the iceberg as far as costs go. There's all the hidden costs, the transfusion associated costs, transport, logistics, staffing, and the time of that staff, and the training of that staff, and the equipment and the consumables that's needed. And then the indirect cost due to adverse events and potentially longer hospital stays. But there's also a cost to the patient, and there's also a cost to the economy, and therefore a cost to the country. I think when COVID hit and a lot of people could not go to work and earn a living due to the lockdown regulations, we were made very much aware of the cost to the patient if the patient cannot work. So like I said, Prof. Axel was a health economist, or he is a health economist. And in Western Australia, they saw that they had a blood bill saving of 18.5 million. But their activity-based costs, their hidden costs, their transfusion-associated cost, they saved between 80 and 100 million Australian dollars. So what I'm trying to tell you guys is that if your blood bill is X, you can multiply X by 3 to 5 times. And that is actually what transfusion is costing your facility. Please keep that in mind. A quick direction change again, and I need to stop and remind all of us about the law, that little devil in the corner. We know Chapter 2 of the National Health Act say the user must have full knowledge, and the healthcare provider must inform the user. We need the consent of the user, and the Chapter 2 is very clear that we must supply adequate knowledge. The healthcare user must participate in decisions, and you all know there are instances when we can administer care without consent. But Section 13 of Chapter 2 speaks of our obligation to keep proper clinical records. So this is the form that everybody feels has too much information that they need to share with us, and therefore they just don't complete it properly. This form is a legal document. This form is a clinical record of a patient. So Chapter 2, Section 13 is very clear that this must be kept at a good quality level. So I'm not going to even talk today about the whole, the whole patient spelling of the name and all of that. Let's skip that. And let's just start here with when you choose what cross-match to do. Do you know the difference between a standard cross-match, an emergency cross-match, and no cross-match? And when I say know the difference, do you know the difference in risk to your patient? Because you are the person that's making that decision to expose the patient to that risk. There where you put in the diagnosis, anemia. And if I could go on to BI while presenting, our BI is our Business Intelligent Data Warehouse, I could show you that 90% of the request forms we receive in 8 provinces of South Africa, either there is no ICD-10 code, or there is a diagnosis written of anemia. Now, how on earth is that and meeting the obligation to keep a good patient record? Then let's talk about all of this information that you think, oh, good heavens, why do they need to know this? This is crucially important. If the blood bank phones me 3 o'clock in the morning and tells me they have got abnormal findings, this is what helps us to determine how serious those findings are and how we should advise you to progress with this case. This is where you sign that you as the doctor has decided to go ahead with this transfusion. And if I was in the room with you, I was going to ask you how many of you have read the red block information directly above where you put your signature, because keeping in mind, this is a legal document. So this is what you are signing to each time you order blood. You say that blood may transmit disease. You know who we collect blood from. You know what we test for and how we test. And if you don't know, keep in mind that you have been signing legal documents to say that you do know this all along. You also know that what it means if I say IDNAT. You also are able to explain to your patient what IDNAT versus serological testing implies in terms of window period infections. You also know that it's stipulated here that you acknowledge that in a country with a high disease prevalence, the test could be negative, but there could still be transfusion-transmitted infections that is present. So the doctor who orders blood must take this into consideration and is responsible for discussing the benefits and potential risks. So if you don't even know how to quantify the risk to your patient of what their chances are to get HIV, how good or how bad our testing is, and you are signing to this every time, doctors. You also say that you have obtained informed consent. And the moment you say that, it means that you have followed the rules for Chapter 2 of the National Health Act of how you obtained informed consent. You also say that all transfusions must be medically justifiable. So if you gave me the diagnosis as anemia, how is that a medically justifiable transfusion? And that alternatives to blood transfusion has been considered. If we don't know that much or not enough, and definitely not enough about patient blood management in South Africa, how can we say we have considered all alternatives to transfusion? Let's talk about ethics a little bit. We all know that the word comes from a Greek term that implies duty, and it's kind of a code of ethics that talks to all our obligations that we as professionals have to respect and that we have towards our patients. So the 4 principles of bioethics, we know this, they haven't changed yet. And we also know that the one is not more important than the other, and there may be conflict. And that which weighs the heaviest in a specific situation should be considered. But when you decide to transfuse, you must base your decisions on these 4 principles. So what does it mean for transfusion? The principle of autonomy. A competent adult have the right to decide what will and what will not be done to their bodies. Informed consent. If I don't know enough about transfusion and the risks of transfusion and the alternatives to the transfusion, can I really give my patient enough information to say that this was informed consent? And when a patient refuses a transfusion, do I document this? Do I have a discussion with my patient about what alternatives is available in the setting that I am working in? The principles of beneficence, that is to be of the duty to be of benefit to your patient. If my knowledge is limited, am I not limiting my patient's options? If I don't know enough about basic patient blood management principles, am I really fulfilling this duty to be of benefit to my patient? The principle of non-maleficence is that I must not do harm or injure or expose my patient to an unnecessary risk. We've seen that there's a dose-dependent negative outcome to transfusions. We know that no transfusion on earth is risk-free. So if I do an unnecessary transfusion, if I transfuse 2 units when clinically 1 would have been enough, if I don't know which product to use in which situation, if my standard of care around transfusion, including the fact that I've seen this patient at outpatients at orthopedics 3 months ago with anemic, and now I'm doing this knee replacement 3 months down the line, and I'm transfusing him because tomorrow he must go to theater and he's anemic, how can I say that I'm not exposing my patient to an unnecessary risk? The use of uncross-matched emergency fridge blood in situations that is not life-threatening, and treating preoperative anemia with a red cell transfusion. The principle of justice that speaks to equal and fair treatment of all patients. We know that blood is a very scarce resource, and just yesterday I posted on the Sub-Saharan PBM group to the South African doctors who's on the group. And anybody on the talk who would like to become part of the group, please let us know and we'll add you to the Sub-Saharan PBM WhatsApp group. And just yesterday, I posted that we are now in a position where we can stop cutbacks, but not at a 5-day level, which is our safe stock level for South Africa, only at a 3.2 stock level currently. So really, we are struggling to get blood to the patient who desperately needs it on all the corners of South Africa. So we cannot waste. It's unethical. And how do we justify not using patient blood management when we know it's shown to be more cost effective and we know we are working in a resource constrained setting? Informed consent, I'm not going to say a lot here. You all know this. The treating doctor specified service, language of the patient's understanding, level of understanding must be written. There must be a witness. And if it's refusal of treatment, then you also need to please document that. You must tell the patient what you're going to do, the benefits, the risks, the alternatives, the likelihood of success, the number of interventions, recuperation time. And although in the public sector, the patient don't have to worry about the cost, we have the responsibility to always think about the cost. I would strongly recommend, please urge you to have a separate informed consent form for the transfusion. The patient will feel that they're involved and empowered. The patient will be protected from unsanctioned blood transfusions, and it will foster a good doctor-patient relationship. And also it will ultimately prevent litigation and civil claims. So now I'm going to leave you with a couple of difficult questions just to spoil your weekend and to make sure that you think about this when you're stuck in traffic this afternoon. Is the absence of active anemia screening and treatment programs not hampering people's ability to reach their full health potential? Is a large part of our population not excluded from active anemia screening and management due to the socioeconomic inequalities we have in South Africa? What is being done about this inequity in access to healthcare? Are untreated anemias not contributing to these inequalities? Given the impact of iron deficiency and keeping the SDGs in mind, can we ignore anemia any longer, especially in a low and middle income country setting? If PBM was considered to be a standard of care by the World Health Assembly more than 11 years ago, why are we only seeing patches of PBM efforts in South Africa? If literature teaches on the negative effects of preoperative anemia, why are almost 49% of elective surgical patients still presenting anemia when we admit them for their elective surgery? If inappropriate transfusions were proven to impact negatively on patient outcomes, why are we still transfusing red cells to correct preoperative anemia in elective surgery patients? In a resource-constrained setting, is it justifiable to not use an option that was proven to be cost-effective? In a resource-constrained setting, given the cost of blood products, is it justifiable to perform an inappropriate transfusion because we do not want to change the date of elective surgery? In a resource-constrained setting, would it not make more sense to screen for and treat iron deficiency anemia to improve general health, well-being, and potentially the socio-economic activity of our population? Do I know enough about transfusion medicine? Do I know about pre-transfusion testing options, specific product requirements, specific product indications, specialized products and specialized services, transfusion adverse events, blood safety and risks? Do I know enough about alternatives to transfusion, intravenous iron, oral iron, for instance, giving it on alternate days for specific patient groups, cell saver technology, tecorotum use, tranexamic acid? What is the quality of our informed consent processes? Are we allowing time and an environment for the patient to participate in the decision-making process? Are we sharing adequate information with our patients, or are we sharing what we know? Are we making our voices heard through discussion platforms, drafting of policy and guidelines to ensure the best interest of our patients? Can we justify still not knowing enough? So I know doctors vary greatly in their enthusiasm for and their experience with blood products, alternatives, and PBM. But the HPCSA expects all of us to have adequate knowledge of the treatment modalities that we expose our patients to. The tendency to limit the patient's options because the doctor lacks this adequate knowledge of well-established treatment modalities is ethically unfounded. We have to ensure that we have adequate knowledge of the treatment options available, and we have to empower our patients with adequate and appropriate information and allow them to participate in the decision-making process. By now, I think many of you have thought, why does SANBS bother to make noise about this topic? They shouldn't be worried. The more blood they can sell, the happier they should be. But here's the reason why. Our purpose statement is trusted to save lives. Now, those of you who are blood donors in the room will know that you take your own time, your own effort, your own cost. You travel to wherever the site closest to you are. You jump on a chair, we stick a thick needle into your arm. Let's be honest, the cookies are not that great. It's really not worthwhile for you as a donor, yet you keep coming back. And we really need you to trust us that SANBS will ensure that the unit that you donated will be used as appropriately as possible. As doctors sitting on this meeting, you must trust SANBS, yes, that when you need the product, we will have the product, and that we will give you a safe product. But I also want you to trust SANBS that we will come to meetings like these, have the difficult conversations, ask the difficult questions, and share important information that would be in the best interest of our patients. The public of this country will trust SANBS to be there, but I think they also need to trust SANBS that we will educate the healthcare providers, the healthcare funders, the actual healthcare workers on the ground with the knowledge that they need to keep the patients of South Africa safe. Our vision is to be a cornerstone of healthcare services in South Africa through the gift of life. And although all of us now think about the blood products, I need to remind you that life is more than just a beating heart. And life also speaks to quality of life. And a patient with chronic iron deficiency or iron deficiency anemia really do not have a good quality of life. This is my second favorite quote. As we men of medicine grow in learning, we more justly appreciate our dependence on each other. The best interest of the patient is the only interest to be considered. And in order that the sick may have the benefit of advancing knowledge, union of forces is necessary. Now, it sounds as if this quote was written specifically for patient blood management, yet it wasn't. It was written in 1910, and still we do not follow this Dr. Mayo's advice. I think it's time to acknowledge that if we want to do what's best for our patients, we need to start talking to each other, we need to take hands, and we need to start working together. Thank you very much for the opportunity.